Hi, good morning or good afternoon, depending upon where you are. My name is Luana Bossolo, and I'm with the APA Practice Organization. Welcome to today's webinar on getting reimbursed, how to successfully bill with CPT codes. This webinar is hosted by the APA Practice Organization, which is a legally separate companion organization to the American Psychological Association. The Practice Organization works on reimbursement issues for psychologists. Because of APA's tax status as a charitable organization, APA cannot legally engage and work on reimbursement issues. And so that's why the Practice Organization is here to help you. So before we get started, I just want to review a couple of logistics. The webinar is being recorded. A copy will be emailed to you within 24 to 48 hours. So even if you happen to hop off early, you'll still get a recording, as well as those who registered but could not make it today. And there will be an opportunity for a Q&A with Dr. Puente and our attorney, Alan Nessman, during this webinar. Please use your chat box on the right side of your screen to submit questions at any time during the presentation. And just so that you know, we received quite a few questions in advance of the webinar, so we're going to go back and forth when we get to the Q&A period between some of the questions submitted as well as some of the live questions submitted during the webinar. And let's go to the next slide. We're going to cover as much as possible regarding CPT codes and specific questions and codes that you submitted in advance. Our lawyer, Alan Nessman, from our Legal and Regulatory Affairs Office, will address your questions regarding challenges with some private insurers. Dr. Puente is going to provide some very important updates today on changes that are coming to the psychotherapy and neuropsychotherapy codes. So I would advise you to stay on as long as possible to this webinar so you can hear about the changes that are coming up this summer. And then we'll go into our Q&A. And right now, I would like to turn things over to our presenters, Dr. Antonio Puente and Alan Nessman. Dr. Puente?
Well, again, good morning or good afternoon, or appropriately, good day. Thank you for joining us, and also want to give a shout out to all the individuals that have been very involved in helping make this happen. On the APA side is Randy Phelps, volunteers have been very active, include Neil Pliskin, Stephen Gillespie, and others have been very supportive in the past, including Jim Georgialakis. This is clearly a team effort, and I want to acknowledge them, and a shout out to also to all of you that I've worked with before, including members of the board of directors. Thank you for being on this call. I want to welcome you on behalf of both the American Psychological Association, of C3, and the American Psychological Association PO, which is, of course, C6. And this is a combination of both educational and, if you will, assistance in making your life more successful as a clinician and a practitioner. I also like to introduce you now to Alan Nussbaum, although before I do that, Alan, let me also explain that all the information that I am sharing does not necessarily reflect the CPT system because, after all, I'm not here representing them. Even though I've been on the CPT panel and representing APA for almost 3 decades. So thank you for your understanding. And Alan, let me turn it over to you.
Sure. Hello, everyone. I'm here to answer questions you may have about private insurance and issues with private insurance and billing particular codes. The one that seems to be the hot question is 90837, and we'll be talking about that a bit. We have our disclaimers here. As you may have figured out, lawyers love disclaimers. I'm not going to read the whole thing, but some key points are we can't give you legal advice. Legal issues are very fact-specific, and in the format of this webinar, we can only talk briefly about some of the things, the issues that come up. So we'll be giving you very simplified versions of what are often 5-10-minute answers.
Okay. Next slide, please. Well, we're very concerned about what practitioners are thinking in terms of reimbursement, for that matter, coding and documentation. And one of the concerns that we wanted to focus on is what do you think is going on that's affecting your practice? So the APAPO came up with this wonderful survey, and we want to share with you the general results of those findings. Alan, what is it that we found when we polled our constituents?
Yeah, so this chart represents the kind of codes that people are having problems with when they're using them. Obviously, some people aren't using some of these codes, but if you look at the chart, on the top we have psychological testing is the biggest problem. Health and behavior codes, which we often lovingly call H&B codes, are the number 2 on the list. Neuropsychological testing is number 3, and then individual psychotherapy, family psychotherapy, and group psychotherapy. That the last group doesn't seem to be having too many issues, but we'll be talking about a lot of these when we get into the questions.
A quick comment before we go on to our next slide. It is surprising to some of us, including myself, to see that psychological testing was a primary concern. We realize this is a relatively small n, and for that matter, that we inappropriately misspelled neuropsychological. Having said that, I do hear on a regular basis not only about the testing codes, but also about the individual psychotherapy codes. So we'll be tackling those as we move along. Now, keep in mind that we received a little less than 1,000 of your questions, and we'll do the best we can to address them, but we will proceed with some of the highlights, and then afterwards we will provide a Q&A for the APAPO publication so we can continue discussing your concerns. Next slide, please. All right, here's a big one. Alan said it. In fact, Alan, why don't you tell us what are the concerns that people seem to be having in the 3437 domain? And then what I can do is explain the difference between those two codes, and we can proceed from there. So what are people calling APA about?
Well, the questions that I tend to field are ones where a company is restricting the use of 90837, and since the codes changed in 2013, a number of companies have said, oh, our costs have gone way up as a result of this new 90837 code. And so we've seen a variety of efforts by companies to try to limit providers' usage of that code. And as we get into the questions, we'll talk about some of those things the companies are doing and the ways we've been responding to those. But a common question is just which code should I bill? And the problem is for a lot of therapists, the dividing line for these codes, as Tony knows better than I do, is 53 minutes. If it's 53 minutes and up, technically you're allowed to bill 90837, and a lot of people are falling right about at that line. But Tony, you want to start with just the overall CPT, the basic CPT picture on that, and how the point that you have to have 53 minutes of time with the patient, et cetera.
So Alan, I have a big question here. Do we code by income or do we code by service? What's the answer to that?
We code by service.
So the big question is not how much you want to earn, but what you actually provided to the client. So let's tackle that. I think that the defining issue is very much time, nothing more than time. Now the big question, of course, is this. Most of us have been billing for 45-minute psychotherapy. That's been considered the standard psychotherapy hour, so to speak. And we've been doing that for most of our careers. Maybe until, for example, 2013, when we discovered that, no, we actually are doing more than 53 minutes, and hence, we should be billing for the 37 code. Well, again, point one, you bill for what you do. Now let's talk about for just a moment, what is it that it defines what you do? What you do for psychotherapy is face-to-face time. So if you're with a client 52 minutes, you bill 34. If you're with a client over that, say 54, 56, 60 minutes, then you bill 37. Now just a word to the wise. Think about the fact that the profession, and maybe many of us, have been billing 3-4 for a long time. So some insurance companies believe that that is the standard psychotherapy code and not the 37. In a recent survey that Gordon Hertz did with the Medicare data set that's available, it appears that most of us are billing the 3-4 and approximately, I think, 50 or so percent. And some of us, like about 20%, are billing about the 3-7 code. So the question becomes, is that an outlier? Well, it could be. So under what circumstances should 3-7 be used for private insurance? And I'll add Medicare as well as Medicaid. Well, it depends. It depends mostly, again, on the issue of time. Let me add another point. Time could be a variable based on a variety of issues. If the client is coming from far away, if the diagnosis is a complicated one, if the situation is complicated, then the possibility of doing a 3-7 seems more likely. Regardless, you may want to consider documenting why you're proceeding with a longer time period, realizing that we have a situation that is both historical and contemporary. We're straddling a very, very complicated situation. Next slide. The answer is, Alan?
So our understanding is that most companies are reimbursing differently for 90834 and 90837. We've had a couple of successful challenges where companies were not reimbursing differently. So, for example, we convinced Aetna to pay more for 90837, and working with our state associations, as we do on most of these challenges, we also convinced Regence Blue Cross Blue Shield in the Northwest to pay more for that code. We currently have a complaint out against Independence Blue Cross in Pennsylvania for not paying more for that code, and we have a complaint against Regence Blue Cross in Utah for paying only a small differential between the codes. If you've heard of another company that I haven't mentioned that is paying the same amount for those codes, let us know. There's an email address at the end of this webinar. Let us know which company that is, and we'll be in touch with the state association and deal with that.
The reason there should be a difference is based on the current procedure terminology system, and specifically the RUC process, or the relative value. It turns out that there is a significant difference between the amount of time and cognitive work associated between the 3-4 and 3-7. Hence, if you look at the Medicare data set, and for that matter, some of the materials that we'll share with you at the end of this presentation, there is a substantial difference according to Medicare, both in terms of value and reimbursement. So no, you should never have the same reimbursement rate. Keep in mind, however, this is an important point, that whatever contract you sign, maybe if it's even in two fonts, really tiny print, it states what you're getting when you have agreed to participate in that particular plan. But going back to the basics, it's about time, it's about cognitive work, and there's a difference between 3-4 and 3-7 historically and currently. Let's go on to the next slide. Health and behavior codes. This is, to put it in simplest terms possible, the way that we deal with all kinds of medical problems that are not, if you will, DSM. This is critical that you appreciate that the diagnosis codes that go with a 150 and 152 are all associated with medical problems. In essence, you'd be working outside the ICD-F chapter. So essentially, this is quite different than all the other codes that we have in our code set. And one of the questions that we have is, can you use this for things like smoking cessation? By all means. Diabetes, COPD, chronic pain, this is the code for those of us that work with, if you will, typical medical clients. This is, or these are not the codes if you're working with typical psychiatric or mental health problems. This is a wonderful code, not only to extend the range of therapy and for that matter assessment services, but essentially brings us into primary care practices as well as all other medical practices. One of the things that's really important and sad is some insurance companies, including some Medicaid programs, I believe North Carolina, for example, basically don't reimburse. So, Alan, as an attorney, how do we tackle this? Why don't you give them the legal interpretation, and I'll give you a slightly different version as well. But these are wonderful codes, in my opinion, highly underutilized, and a wonderful way to get psychology integrated in all of healthcare.
Well, first, I totally agree with Tony's assessment of the importance of these codes in getting psychologists involved in integrated care, and this is how you get paid for it. We still have some complaints that companies are not doing this. What we have found and what some of our members have found is that if you get up the chain of command in the company, you can usually find somebody who gets it and can get the problem fixed. But if not, if you try going up the chain of command and it's not working, let us know. The usual problem we see is it's a structural problem that mental health claims and medical claims are being paid out of two different entities or different parts of the company. And we get what we call the ping pong issue, that the mental health side says, oh, we can't pay this code because there's a mental health diagnosis, and the medical side says, oh, we can't pay this code because the person is a mental health professional, they're a psychologist. And usually we can, if you get up the chain of command, you get somebody who realizes, oh, these codes are meant for psychologists to be billing for a medical diagnosis, as Tony says. The other argument we make is that it's just foolish for companies not to be paying these, because the small amount they spend on the behavioral health interventions from a health psychologist can save them huge amounts of money with very expensive chronic conditions like diabetes, hypertension. Psychologists can help with behavioral issues like medication compliance, diet compliance, exercise compliance, those kind of things, and just that small amount of money can save huge amounts of money on the medical side. And that's one problem when you don't have integrated systems. They may not care on one side because it's not their cost. But if you move up the chain of command, people usually realize, at least the medical side usually realizes, hey, this is good for us to be paying these codes.
Here's an alternative interpretation, and that is, you ever wonder why you should join APAPO? Or, for that matter, why should you join your state association? These are the folks that make these changes occur. Sometimes you can do it by yourself or with a group of you, but when you have an association like the North Carolina Psych Association and the American Practice, APA Practice Organization, you clearly have the power and they will listen to you. So join them, get them to work with you and for you to make these changes occur. It's in the best interest not only of the client, but also of the bottom line in the insurance company to reimburse the health and behavior codes. Now,
I was going to add, before we move on, Tony had mentioned that there's some Medicaid, a lot of Medicaid programs do not pay for H&B codes, and that's one of our priorities in our office, Legal and Regulatory Affairs, is pushing to get Medicaid programs to recognize the H&B codes. And particularly in Medicaid, you have populations where the behavioral aspects are huge, and once they see the light, they usually get it. But it's an advocacy push, as Tony points out.
Yeah, the whole business is to push forward on educating these folks. Very often, it's not that they don't like us, they just don't understand us. So let's educate, and if you will, advocacy, it should be first and foremost in everybody's agenda, including those of us who are in the front lines. All right, next slide. So what's coming forward as we begin to wrap up this portion of our presentation? Well, I should tell you that every code is always up for change. Sometimes not right now, but at the present time, we're very interested in several issues. Let me share with you. One of them is that H&B codes need to be reconsidered. 1. 2, integration of health care and integrating psychological care in all of health is obviously a huge issue for us. We believe that collaborative care, a model that's been proposed by psychiatrists, is insufficient, incomplete, and in many ways untenable. But it's not really what we're working on right now today. There's only so much we can share with you because, among other things, we're bound by confidentiality agreements, but we are very, very concerned about the structure of the testing codes, both psychological testing and neuropsychological testing codes. So in working carefully with the folks at APA and APA-APO, and many of you. In fact, there's been a wonderful group of individuals that have been advising Dr. Phelps and others in making this happen. We have a new proposal that's going to be presented. Let's keep our fingers crossed, and once we do that, we may be in a position to go to the next step, which of course has to do with valuing these codes. Let me go on to the next slide. I wish I could tell you that it's very easy. We just dream up a code and that we have all the power and control not only to get these codes in the book, but also to get these codes valued correctly. Our testing codes initially took almost 10 years, and after that, we spent another 10 trying to revise them. Now we find ourselves in a situation where we're going to present them again. We're going to basically come up with a model that's going to be more reflective of the kind of services people do, and also more appreciative of the system that the AMA and CMS has in terms of reimbursing all of healthcare. Keep in mind, we only really work with about 50 codes, and there are about 8,500 codes. So we come up with codes that are divergent, very divergent. They don't understand it, and in many ways, they just simply don't pass them. One of the challenges that we have once we get these codes done is valuing them. Sometimes people have said, well, we have all the power to set the value. Well, actually, there's two parts. Let me talk about one, but briefly mention the other. One has to do with a conversion factor that's set by Congress. That's really impossible for us to control and affects all 8,500 CPT codes. There's another part, and that other half, if you will, is developing of a relative value unit. We actually set that. And we do that, as you see in this slide, through a very complicated process. It involves asking you for information, and then in turn it goes through a series of steps, very slow, very vetted out, and where we have to be challenged by, if you will, the other 130 health professionals that make up the health economy in the US, which by the way represents about 17% of the gross domestic product. We have to get them to believe that what we do is valuable and that our interpretation theoretically is plausible. This is a very long, very diplomatic, very complex process, and really, among other things, brings into question when people ask, how come you got that value? Let's go on to the next slide. Well, actually, we get it through you. This is the RUC survey process. We cannot just go to the table and say, this is what we think. We actually do a survey that's set by other individuals, not us, although we are part of that development of the scientific instrument. And then, in turn, we send it to a random sample of you folks. That is what determines the RUC value or the RVU value. That number is then multiplied by the conversion factor to get to the Medicare reimbursement. So here's another way to look at it. You are part of determining what is the final amount that we're going to get reimbursed. And as Medicare goes, everybody else goes. If it's Medicaid, it's below. In some cases, if it's private insurance, it's above. But it's a benchmark which we all live by. So you are the one that's helping determine the value of these codes. Next slide. So once the surveys are completed, we review the data and we go through presenting the information to the AMA RUC meeting, which is a very, very challenging task, not just for us, but for all healthcare professionals. Once those values are determined, then it finally goes to CMS, who decides whether that value is correct, too low, or too high. Then the so-called physician's fee schedule comes out. That is what determines our reimbursement. Next slide, please. So What about the survey? We get you simply randomly. Hopefully you're part of the APAPO, and if you are, that's where our sample comes from. The survey is completed by you without us telling you what to do, and the components of the survey are really pretty straightforward. They have to do with how does the service that we're proposing compare to a pre-existing survey that has been valued? Is it harder? Is it easier? Does it take more cognitive work, more emotional, if you will, demands? That is basically what you're trying to look at. Now, here's the problem. If we're taking, for example, testing, when we're doing the survey of testing, we're looking at 1 hour of one code. So in other words, we're looking at a slice, not the loaf. So we're not asking you to, for example, review an entire neuropsych evaluation. Every code is 1 unit. For example, in the case of H&B, it's 15 minutes. In terms of psychotherapy, it could be 45 or 60 or, for that matter, 30. In testing, every unit essentially is 1 hour unit. So that's what we're asking to do. How does 1 unit compare to other things that we do? And the values are based on how much do you have to think, how complicated the work is, how emotionally demanding it is. Now, if you want to learn more, next slide. There they are, APAPracticeCentral.org. Alan, you want to say a few words about the valuable products that APA Practice Central comes up with? I cannot hear Alan.
Oh, sorry, I was on mute. So we cover a lot of the issues that we're talking about in this webinar, particularly in the Practice Update e-newsletter, for example. Some of the challenges we've had against insurance companies on their 90837 policies are covered in articles in the Practice Update newsletter. And I believe some of these are also covered in the Good Practice magazine. But if you have an issue, you can go to practicecentral.org and do a search for it, and a lot of things you may be looking for will come up. And we're also planning to do more articles based on some of the questions that have come in. We've had over 800 questions, so there's a lot more than we can cover in this webinar, but we're going to be mining that to respond to some of the most frequent questions that come up.
Which one of the more common questions besides the 3.4 and 3.7 is found in the next slide. Can you use 96116 and 118? How does it work? How does all this work? And what if I'm limited to 7 hours? What's a billable time? Well, first of all, there are 2 kinds of testing codes. They are, for example, what we call psychological testing codes, which essentially would be matched with DSM or the F chapter of ICD. And that would be psychiatric interviewing and, for example, 101 and so forth. If, on the other hand, your problem or the problem of the client that you're seeing is a neurological problem, like, for example, TBI, multiple sclerosis, so forth, then for interview would be 1.6 and then 1.8. So essentially, you match an interview code with a testing code. Now, you can also, if you want, add a technician code. And if you like, you could also add to that the computerized testing code. For example, in terms of English, that could be 120. So these are meant to be matched. Here's a different question, though. Can you do 1.6 and 1.8 on the same day? You should be able to. But everything that Alan and I have to say is going to be trumped essentially by the contract you have signed. Some insurance companies have limited use of these codes on the same day. A bigger challenge is the question, can you use a psych testing by professional and psych testing by the technician? Medicare is very vocal on this issue, but most private insurance is not. And essentially, the difference is that theoretically, 1.8 or 1.9 are often associated with things that should not occur in the same day. If you look carefully, they should be able to occur in the same day, but there's a challenge in many of the Medicare carriers' interpretation. That's one, among other reasons, that we're considering proposing a new codes. But essentially, these codes should be all together. If you think about it, you have three silos: a mental health silo, a health psychology silo, and a neuropsych silo. Each of those have, if you will, an interview code, a testing code, and for that matter, a therapy code. Now, as far as the hours, this depends on each of the carriers. Some carriers will allow as few as 5. Some are fairly open. You have to be careful, because if you do not have more than, say, 7 hours, what am I to do? Alan, what am I to do? If I feel like I need to do 10 hours worth of testing and the insurance carrier tells me I can only do 7, what's my legal and, for that matter, ethical concerns? How do I work this very difficult balance?
Well, we generally recommend that you write down the time that you're actually spending. And one of the reasons for that is that if people sometimes think, well, I'm only getting paid for 7 hours. I spent 10 hours. I spent 11 hours. The problem is, if you're only writing down the time that you think the company will pay, that becomes a self-fulfilling prophecy, because then the company will say, well, gee, look at this. Everybody seems to be able to do this testing in 7 hours, and you, Mr. Lazy over here, have to takes you 10 hours, but that may just reflect that people aren't writing down time that they're not expecting to get paid for. So it's important to write down your actual time, even if you recognize you're not going to get paid for all of your time.
One of the things that we do in my prior practice, which is a hybrid of electronic and paper, is we have a paper trail that everybody logs in, time out. And of course, unlike psychotherapy, which is face-to-face only, and for that matter, HMB, both the psychiatric interview and all the testing codes, as well as neurobehavioral status exam, are face-to-face plus all the other professional time. So we write this in this one face sheet, if you will, and then in the testing, actually in the face sheets, we do start and stop time. So if you're in doubt, document. It's not the amount of time that has elapsed, it's the start and stop time of the professional and technical work that occurs. And if for some reason you're billing more than the hours associated with what the contract, you need to go back. Either change your practice parameters, or alternatively educate and advocate that the insurance company provides the appropriate number of hours to take care of the clients that they're seeking to serve. Let's move on to the next slide. Now, at this particular point, we find ourselves at about 20 minutes left to go, and we realize that you have lots of questions, and we may have some answers. So let's see if we can move on with that, and then towards the end, we'll stop and have a couple of closing comments for us to share with you. So out of those 800, I think we have chosen some questions. So let's see what you have. Luana, could you share with us?
Sure. Hi, everyone. This is Luana. As Dr. Puente said, we received over 800 questions from all of you in advance of this webinar. You can still submit questions during the webinar. Just type them in your chat box on the right-hand side of your screen. And I just want to let you know that the questions we're not able to get to today, we are going to do a follow-up questionnaire and release it through our electronic newsletter, Practice Update. So this one is really for Alan. We received a number of questions from many of our members about ominous letters from insurers regarding above average use of 90837, as well as threats of audits. Alan, can you address this?
Sure. As I mentioned earlier, insurers have tried a variety of ways to suppress 90837 usage, and one of those is what we call the ominous letters approach. Typically, the letter looks to the psychologist like it's saying, you use this code a lot more than your peers. Here's the average, and here's you way up here. Big Brother is watching you, and you'll get hit with an audit if you don't change your practices. So we've addressed this issue with the Anthem Blue Cross Blue Shield companies, with Highmark Blue Cross Blue Shield, and with Medical Mutual of Ohio. And all these, we're working with our state psychological associations on that. And the companies, the subcontractors that we're sending out the letters we've seen have been Equiclaim and Change Healthcare. In these cases, we've confirmed with the company that these letters are just educational. They're just making sure people are properly using the codes. For example, that the 53 minutes is time spent face-to-face with the patient, that people are recording stop and start times for using 90837 as the practice organization recommends, and that they're not going to take action against any psychologists who are correctly using the code, even if they're using it a lot. If you're experiencing something different with any of these companies, different from what they've assured us and what we've assured you, let us know using the email that you'll see later on. Also, if you've heard of other companies that are sending these ominous letters, and some of them really do look ominous, but we have confirmed with the companies that have sent the ones we've seen so far that these are just going to be educational. They just want to make sure people are using the codes correctly, and they've assured us that they're not going to take action against our members who are properly using the codes.
This is Luana again. I just want to add, I've noticed in the chat box that some folks joined a little late, and they have questions about the specific codes that are being discussed today. So this is being recorded, and this recording will be emailed to the entire 523 people who are on the webinar right now, so that you can go back and listen to it from the start. Dr. Puente, did you want to respond to what Alan just shared?
Yes, I want to add to, let's look at this from the standpoint of the insurance companies and from the standpoint of us. Here they have a situation that for as long as we've been involved in the insurance world, we've been billing 45 minutes, which is reimbursed at a certain amount, say X. And all of a sudden, we have an influx of Y, which is substantially higher. So in the case of Medicare, maybe about $30 or $40 higher. So they're going to say, aha, here's what's going on. These people are gaming the system. Let me give you an example of that. One of the medical policy folks at AMA has actually said to me and to several of us that work on CPT, why are you doing this? And we sort of said, this is not we doing it, it's just this is the nature of the beast. We've been doing longer psychotherapy historically, and one way you could say, well, we've been underbilling. And the response is, this is out of our hands, now it's going to the audit world, so to speak. So they're trying to figure out, why is it that we're doing more billing, if you will, that we have been done historically? Well, you could argue it's just that code wasn't there. Now, a word to the wise. Keep in mind that only about 20% of us are doing that on a regular basis with regards to Medicare. But since this is considered by some to be atypical relative to your peers and relative to our history, document carefully why the, quote, longer psychotherapy may be of value. I give you some examples. Infrequent visits, patients having to come from far away, complicated problems, diagnosed comorbid situations, whatever. Document that. So if in doubt, document.
Hey, Tony, I wanted to add something. You had mentioned the about 20% usage in Medicare, and I deal mostly with commercial insurance, and I was actually surprised how much the shortest code, the 30-minute code, is used in Medicare. And with commercial insurance, with some of these letters that are the ominous letters that say this is the average usage of 90837 is actually much higher for some of these companies. I forget offhand, but it's at least for some of them around in the 40%, 50% range. So I think because of the different population, you're not dealing with elderly patients who don't have as much stamina to go through a long therapy session. I think the usage rates are higher.
Right. And the difficulty, Alan, is that we don't have easy access to that data,
right.
Which makes it tough for us to be able to provide specifics.
Right, right.
What other questions can you come up with, Luana? Make them easy so we can answer them.
Well, I got one just for you, Tony. It's right up your alley. So this question says, as a neuropsychologist, how can I bill for time spent scoring, interpreting, and writing assessments, not face-to-face time?
Well, easily. Just do it. And let me explain. If you're the one that is actually doing the test at the present time, you can score for selecting the test, administering the test, scoring the test, interpreting, and report writing, as well as follow up with the client or significant others. That is built into the testing codes. That is not built in, however, into the psychotherapy and H&B codes. So it's there. Use it. Otherwise, you're engaged essentially in underbilling.
Okay, great. Thank you. Okay, so we've got another question, and I think this one is for Alan. If private insurers say it won't cover a service, can I charge the patient for it?
Yes, and so this question comes up both when the company says we're not covering any of that service, or in situations where, for example, they may say we'll pay for 5 hours of testing, but we're not paying for anything more than that. And the question often comes up, can I charge the patient for it? If you're not in the company's network, the answer is pretty simple, yes. If you are in the company network, you need to check your provider contract. And what we've seen is there's really variation between different provider contracts in the way they word this. Typically, you can't charge the patient more than the contracted rate with the company, but then they tend to have different language on exactly what happens if they're not covering it. For example, they don't think it's medically necessary. In some cases, they actually have you do a waiver with the patient to make sure the patient understands that this is outside of the insurance coverage, et cetera. So check either the provider contract, or if it's not there, perhaps the provider section of the website. And some of this language is not very clearly worded, so if you're unsure, check with your network representative with the company and get an explanation from them. And then I recommend that you confirm it in an email. So if someone comes back later and says, well, how are you charging the patient for this? You have the email to say, this is what I was told. I confirmed that with the company, and nobody told me otherwise. Tony, do you want to add anything on that?
Let me ask you a quick question. When should I have the patient sign that waiver? At the beginning or at the end when I realize, oops, I'm not going to get reimbursed for those 3 additional hours?
You know, I forget how that particular company's policy worked. I believe that was Anthem of Ohio, but I think they had a very detailed procedure there. So that would probably say that's the only company I've seen that has had a specific waiver procedure. But obviously, if you don't know until later, oops, I'm going to have 3 extra hours the company won't pay for. You can't have the patient sign the waiver before you knew that you're going to go over the limit.
So a good rule of thumb is basically have everything cleared up right at the beginning. So both the client and you know what the responsibilities of each and what the economic situation is going to be at. If you can't work it through, then at that point you may want to sit down and discuss such issues as waiver or alternative forms of payment.
Mm-hmm. Okay. I've got another question for you, Tony. How do I get the insurer to bill medical versus mental health on neuropsych evals for medical problems like Alzheimer's?
This is a very difficult issue, and Alan actually already addressed this, at least to a degree. If you're working in the ICD-F world or the mental health world, your life is going to be pretty straightforward. If you're dealing with RS, some of the G codes, then that becomes a major challenge. And as he says, essentially you have 2 parts to all this. Part 1 is your, if you will, ICD code, your diagnosis code. Is it an F code or is it something else? And 2, are you an MD or are you a PhD PsyD? Sometimes what happens, insurance companies will boot you out, even though you have an appropriate R code, a medical code, that puts you in the health plan rather than the mental health carve-out. But that becomes a major problem when then they see, aha, you've got a PhD or PsyD. Here's my suggestion to you, and I've done this as long as I've been involved with insurance, and that is, if you have the option, get yourself credentialed as a medical provider, not a mental health provider. However, if you have an option, consider both the mental health and the medical, because you could end up with dementia and depression. And that allows you to do both psychotherapy and other things such as cognitive rehabilitation or whatever else is necessary to rehabilitate the client. So keep in mind that you are very often going to be considered a mental health provider, even though you're not working in the mental health world. Difficult, challenging.
As Tony said, that's what I was talking about earlier with H&B codes. You get this ping pong problem where they say, well, wait, this is stroke or TBI. It's a medical diagnosis. We've seen less of that. You know, I used to get a lot of those complaints. I've had a lot less of those lately. But again, if you're unable to resolve that, and it's the same thing as I said earlier, try going up the chain of command. Usually somebody who's not the frontline person but a supervisor ought to be able to get this. You know, unlike H&B codes, which are, you know, relatively recent, neuropsychologists have been billing for medical diagnoses for a long time. So this is a problem that really should have gone away. But if you have a problem and you're unable to resolve it, contact the practice organization.
Hey, Luana, can I ask a question that I'd like to entertain? I am receiving $75 an hour for psychotherapy. I think that's just woefully inappropriate. Can I negotiate my contract with a particular carrier? Alan, can we do that? Or are we just set in stone? We have to live by that.
Sure. The answer is yes, you can. And a lot of people are very successful at negotiating better rates. It really tends to depend on how crowded your area is, what the competition is like, and do you have a particular specialty? And some companies are better at realizing that it's a mental health professional, it's not a mental health professional, it's a mental health professional. Some companies recognize that, like eating disorders, child and adolescent psychology are specialized fields, and those are hard to come by. The one thing I will remind people of is that you shouldn't discuss your private negotiations on a listserv, because that creates antitrust problems, which are too complicated to explain here. But we definitely encourage people to try to negotiate rates, but just don't talk about it on the listserv, because that gets people into dangerous waters, and we don't want to have those kind of problems. But yes, you should do it. And I believe in the past we put out some guidance on that, and maybe we should put out some more.
Well, I think we have about 5-7 more minutes worth of questions, so continue with remaining ones.
Okay, so this one's for you, Tony. Someone is asking, can you address the codes for emergency situations that include billing for time spent out of session?
Well, there's actually a specific set of codes that came up and were developed during the 2013 cycle, and those are what we call the crisis codes. And those codes allow you to bill for additional time away from the actual face-to-face time, and theoretically you could be doing this as long as 24 hours. So my suggestion for those individuals that are having to deal with a complicated, life-threatening, and life-threatening doesn't necessarily have to be physical life, it could be mental life. If that is that significant, then you may want to start thinking about the crisis codes rather than the psychotherapy codes. This is a brand new concept and something that we all should be attentive to, especially those of us who worked in ER and with complex clients. So there's a set of codes, take a look at them. And I'll give you some suggestions in a few moments about where you might find additional information.
Okay. I do want to ask, we have a question from someone who's identified him or herself as a geropsychologist, and this professional asks, is there a way to see a patient and their family separately on the same day, both for a full session?
I guess the question is for what? For intervention or for psychotherapy? If it's for intervention, the answer is there are very few codes that insurance companies like to pay for non-face-to-face time with the client. However, the new psychotherapy codes are fairly robust in that they suggest that you could do that. So the question becomes, to be really specific, how low can you go? In other words, if you have to see the client, can I do it for 1 or 2 minutes and then see the rest of the family? The answer is technically you could, but it depends on the insurance company and the codes that you use. If it's all about assessment, ample opportunity, both for the psychiatric interview codes and your behavioral status exam to allow you to see and discuss the situation with them. For that matter, that applies also with follow-ups. Sometimes the client is not in a position to be able to receive the follow-up, so you may want to provide that to a significant other or family members. Having said that, please document, one more time, please document that information so in case you get audited, you're covered.
Okay, great. I have a question for Alan. Are there any limits on the number of weeks a psychologist can bill for more than one session a week or for 60-minute sessions without getting denied or audited?
So this is let me split it into two of those. We've talked about the 60-minute code, but with both of those, what I would say is a lot of companies are managing the outliers. This is actually something that in the settlement of one of our lawsuits against the managed care companies, the California lawsuit we had back when I started 17 years ago, we were arguing that the company shouldn't just be doing utilization review with every psychologist, with every patient, every session, because most of it falls into common patterns. It's a waste of everyone's time. So the companies, a lot of them have really picked up on our advice from 17 years ago, which is manage the outliers. The thing is there won't really be typically a set outlier because it depends a lot on the diagnosis. So the thing is, the one thing I would say though is that seeing a patient more than once a week, I do get a number of calls from members saying that has flagged them for an audit. And as Tony would say, one of the main things you want to do is you want to document why you're seeing the patient more than once a week. Sometimes with these audits, the company's just checking in and making sure you have a good reason for that. And often the patient will be in crisis. The thing you want to avoid is something where all of your patients are in multiple times a week. A lot of companies are considering more than once a week of therapy as sort of the luxury, the Cadillac of care, and that does get flagged. Similarly, with the 90837 usage, it really varies by company. We've at least seen a window. As Tony points out, we don't normally know what the usage is, but that's the one advantage of these ominous letters is they tell you for that company what the average is. Usually you don't know what that is, but the main thing is, what I would say is just document what you're doing, is what Tony has said, so that if an audit comes, a lot of times the companies are just checking to make sure that you've got a good reason for the billing pattern you have. But particularly with the more than once a week usage, I would try to limit that, and if you do need to use it, just document why you're using it.
Let me ask this follow-up question. I'm out of network. Do I need to worry about these guidelines? I'll give you my interpretation as a clinician, and I'd like to hear Alan's interpretation as an attorney. The idea is, no, you don't have to, because there's no exchange between you and the individual setting these policies, financial exchange. However, if you get challenged in a, say, for example, ethical complaint or a legal complaint associated with the delivery of your services, they will use this foundation, this standard, it's this benchmark, to determine whether you were an outlier or not. So, for example, if you're being the therapist to a movie star and you're seeing them 7 days a week, and the movie star decides that you're not necessarily being responsive to their needs, then it becomes a challenge, because that, again, as we've said a few times, you are an outlier. Alan, what do you think about that?
Yeah, well, I would add to that. That's a great question, because we get that a lot. It's like, I'm out of network. Why do I need to respond to this insurance company? They've got no contract with me. I have no obligation to them. The problem is that it's a triangular relationship. So we often tell our members that if you don't respond to the insurance company asking, for example, why was this patient seen twice a week, your patient is likely to get denied care. So we recommend that you do respond to reasonable requests from the insurance company about that patient's care, because you don't want to take the attitude of, I'm not going to be involved, and then your patient gets denied care. That's not a good result.
We realize that we haven't really met all your needs in this very brief seminar, and Luana has assured us that we're going to basically do a good scan of the 800, 900 questions that we received and provide responses to them as a Q&A, and maybe we might, if you think it's appropriate, we might have a follow-up conversation with you later this summer. But for right now, I really want you to appreciate the importance of the APAPO. They're the ones that are making all this happen. It's not APA. APA has a venerable 125-year history. We're going to be here for another 125. But you remember, the APA deals with psychology. The APAPO deals with psychologists. And maybe a few quick words on that. If you benefit from what we're doing, you should be part of APAPO. And let me add one more plug. Not only APAPO, but your state association. As we move forward in this shifting healthcare environment, the states are going to be determining much more of our healthcare life than the federal government has historically. So we need to have a foot at the state capitol and a foot in our nation's capital. A foot with our state associations and one with APAPO. We look forward, if you're not part of us, to join. If you're part of us, here is the kind of thing we're doing behind the scenes. Alan, any last minute comments from your part?
I would just say that most of the advocacy that I've talked about has been advocacy that's been done by the practice organization working with our state association. So all that stuff pushing back on ways to limit 90837 usage is done by the practice organization and working with the state associations. Tony's exactly right. This stuff wouldn't happen without the practice organization or the state associations.
Now, if you want some additional information, the next slide provides some. Of course, the AMA process and the AMA CPT you could find, as well as lots of articles in the APA Practice Central disclosure. I put together a psychology coding website many years ago, and it provides all these CPT codes and my interpretation of how to use them. So that's another source of information. As we move forward, thank you today very much for you participating in this webinar. Thank you, Alan, Luana, the APAPO staff, and the several hundred of you that are part of our webinar today, and the couple of thousand or so of you that have also signed up. We appreciate you being part of the process. We look forward to having you part of APA and APAPO. For right now, Luana, can they get this some other way?
Hi, thanks, Tony. So we'd like you to stay online for a few extra minutes. We're going to send you a short survey, which should pop up on your screen shortly. We would like your feedback on today's webinar, as well as other information you would like from the practice organization. And I do want to mention that the Good Practice magazine, which was highlighted during this webinar, is a benefit to those who pay dues to the practice organization. So some of you may already receive it. If not, you can go online to apapracticecentral.org, and you can renew or join the practice organization member, provided you're already an APA member. And you can start receiving the next issue of Good Practice magazine, which is due out in early June. So thanks again for attending today.
And
on behalf of APA and APAPO,
the email for emailing questions.
Yes.
yes.
Good. Thanks, Alan. So if you have questions, you can email us at practice@apa.org. So if you have questions for Alan or our legal and regulatory team regarding issues with health insurance and managed care, private and government insurers, you can email us and we'll get those questions to them. And we'll also get your questions to Tony Puente. Anything else, guys?
Again, on behalf of APA and APAPO, we appreciate you participating. We appreciate you being in the front lines. Let's work together to make this happen. Have a good day.
Thanks.
Thanks, everyone.
Bye.
Don't do that. Oh, wait, Barbara.